So anytime somebody presents with early stage disease and you treat them with all the standard adjuvant therapy, and then they have a recurrence, they come in with symptoms or they come in with a CAT scan or a bone scan that shows metastatic disease, it is critical to one thing that's absolutely critical that medical oncologists are taught to do is you have to rebiopsy because rebiopsy is very important to establish that the recurrence of the disease continues to be estrogen receptor positive, because in up to about 30% of cases, it can change. It can no longer be estrogen receptor positive. It can now become triple negative, or it can even become HER2 positive. So it is critical to rebiopsy to prove that the recurrence is estrogen receptor positive. Now, if the recurrence is not estrogen receptor positive, you can reasonably assume that it's basically a subclone of cancer cells that were never going to be responsive to the estrogen receptor. But if it is estrogen receptor positive, then that group of cells have developed a bypass mechanism for our effective drugs, and they're no longer responsive to our effective drugs like tamoxifen or aromatase inhibitors. But rebiopsy is critical, and we learn so much about the cancer when we rebiopsy. We learn about, is it ER positive? Is it PR positive? Is it HER2 positive? But also, now we learn about next generation sequencing. What mutations are in that cancer cell that make that cancer cell, that group of cancer cells, unique to that patient?